Welcome, everyone. The American Society of Nuclear Cardiology is pleased to present this online seminar, Cases in Tc99m-PYP, Evaluation of ATTR Cardiac Amyloidosis, Interpretation and Reporting. My name is Jennifer, and I'm your facilitator. If you need help, simply send us a message in the chat box in the lower left corner of your screen, and then do be sure to click on the Send button. Today's presentation will last for 1 hour. Take a look at your links box just above the chat box. Here you can open a PDF of the slides. If you have any questions, please type those in throughout the event right there in the chat box as well. Please note there is no credit for this event. I'm now pleased to turn this over to our moderator, Dr. Jamieson Bourque, Associate Professor of Medicine and Radiology, Medical Director of Nuclear Cardiology and the Stress Laboratory, Medical Director of Culpeper Cardiology at the University of Virginia Health System. Dr. Bourque, welcome.
Thank you, Jennifer, and I want to give a hearty thanks to the ASNC team for putting our team together and this important webinar, and want to thank my fellow speakers. We have Ed Miller from Yale, who's Director of Nuclear Cardiology there, as well as Director of the Cardiology Fellowship Program. Dr. Malhotra, Saurabh Malhotra from Cook County Health, and an Associate Professor of Medicine at Rush Medical College. And Brett Sperry, Dr. Sperry is Co-Director of the Cardiac Amyloidosis Program at St. Luke's Mid-America Heart Institute in Kansas City. We have a really exciting agenda for today. I'm going to give a brief overview of interpretation and reporting, and then our team has a great set of cases and some associated practical points to go with them. And we're going to finish up with an expert panel discussion and audience question and answer. You can put your questions in the chat box. And given that we have a lot to cover in a relatively short time period, if we can't get to all questions, we may go over a tiny bit if we have to time-wise, but also we'll be sure to address any unanswered questions over email after the fact. And so I will go ahead and get started with the introduction. Here are my disclosures. So our learning objectives for you today is for you to be able to apply a structured approach to the interpretation of Tc99m-PYP images for the assessment of ATTR cardiac amyloidosis, and for you to be able to assemble a comprehensive report using best practices. I want to refer you to multiple resources from ASNC that are available, including the expert consensus recommendations that I co-chaired with Dr. Sharmila Dorbala. Part 1 deals with evidence-based and standardized methods of imaging, and then Part 2 deals with diagnostic criteria and appropriate utilization. There's also a practice points that has been recently updated that is a great resource for you as you're putting together a lab. So when we think about interpretation, there are multiple steps to the process. The first is to perform a visual interpretation, and importantly, we need to do SPECT imaging in addition to any planar imaging, because we need to confirm that there is diffuse radiotracer uptake in the myocardium on SPECT imaging in order to proceed further. If there's no myocardial uptake present, then the study should be considered negative. If myocardial uptake is present, then you would proceed to step 2, which is the visual grading. And it's important to do the SPECT imaging particularly because we need to differentiate myocardial uptake from blood pool uptake. And there's been debate in our group about whether it's necessary to repeat imaging at 3 hours if there is blood pool noted. There is recent data that suggests that particularly if you have a SPECT CT, you may be able to adequately determine whether someone is going to have myocardial uptake or not at 1 hour. If there's any question, then repeat imaging at 3 hours can be very helpful to do visual grading at that time, as the blood pool will have cleared. For step 2, semi-quantitative visual grading is performed, and then when necessary, HCl ratio assessment. And visual grading is from grade 0 to 3, and it's based on whether there's any uptake present and then whether the uptake is less than, equal to, or greater than the ribs for grades 1, 2, and 3, respectively. And also it's important in looking at the SPECT imaging to determine whether the uptake is focal, diffuse, or focal on diffuse. And when we think about, so the visual grading is really the hallmark for how we're making the diagnosis. However, there's some situations where it would be helpful to do additional HCl, heart to contralateral lung ratio assessment. And I'll talk about that in a second. So you draw a circular region of interest around the myocardium, trying to avoid sternal overlap or adjacent lung, and then an equally sized region in the contralateral lung in order to measure background. And the HCl ratio is the ratio of the heart mean counts to the contralateral mean counts. But importantly, the HCl ratio is not sufficient to diagnose the ATTR cardiac amyloidosis. So if the HCl ratio is, or excuse me, if the visual grade is 0, then you don't want to use the HCl ratio because it can be confusing and it may be myocardial, or excuse me, blood pool uptake that you're seeing. Likewise, if the visual grade is 2 or 3, then you have a diagnosis, and having a lower HCl ratio may be due to artifact or to misplacement of the regions. But where HCl ratio can be helpful is differentiating grade 1 versus grade 2 and using a cutoff of 1.5 at 1 hour or 1.3 at 3 hours. And the HCl ratio has been shown to be useful for prognosis. So it still has a role. It's just there's been increased emphasis on using the visual grading. And I had mentioned before the importance of SPECT reconstruction just to make sure that the uptake that you're seeing is not in the blood pool rather than the myocardium. So when we do our reporting, there are 6 key elements that should be included in a complete report. One is demographics, including the reason for the test, basic demographics that you would normally have, such as the patient's name and date of birth and those sorts of things, but also reason for the test, prior imaging results, and any biopsy results. Those can be helpful to place this test into context. Methods, including the radiotracer dose, importantly, the interval before the scan after injection of the radioisotope, and whether planar SPECT and CT were used. And then there's a findings section where one should comment on image quality, the visual scan interpretation, the semi-quantitative visual grading and the score that is that you give the test. And then if it was performed, the quantitative heart to contralateral lung ratio. And then finally, you'll want to include any ancillary findings, such as whole body imaging or ancillary findings on the CT used for attenuation correction. Finally, the conclusion. And the conclusions should include overall interpretation, such as which should be not suggestive, which is the visual grade of 0, equivocal, which would be a visual grade 1, or an equivocal visual grade 1 or 2. Again, this may be an area where the HCl ratio could put you over the edge, or strongly suggestive, which would be a visual grade of 2 or 3. And then following that overall interpretation, then an AL amyloidosis evaluation statement would be particularly helpful. So again, not asking labs to look to see if the AL lab testing necessarily has been done, but having a statement that says that evaluation of serum free light chains and serum and urine immunofixation is really important in all patients because any degree of uptake can be seen with AL cardiac amyloidosis. So you have to make sure that you have ruled that out before making a definitive statement that this is suggestive of ATTR cardiac amyloidosis. And finally, it can be helpful to add a statement about interpreting in the context of a prior evaluation, such as considering referral to a hematologist or an amyloidosis expert if the echo or cardiac MRI is strongly suggestive, but the PYP is not suggestive or is equivocal, or if there are abnormal or equivocal free light chains or immunofixation, then that would be a situation where additional referral and management may be helpful. So I know that's a whirlwind overview. Our speakers in their cases are going to get into more specific examples, so I don't want to take any more time. But I do refer you back to the consensus statement and the practice points, which have good sort of outlines of this material. And I have talked about the AL lab testing importance. Just to mention that the Image Guide Registry is going to incorporate amyloidosis in the future, and I put a couple of example parameters that we'll be looking at, but there'll be a very comprehensive inclusion in Image Guide, which I think will help for guiding both quality and research. So without further ado, I will turn it over to Dr. Miller, and we'll get into some cases.
All right. Thanks, Jamie. I hope everybody can hear me, and thanks to FASNC for putting together this session. So I've been tasked to provide 3 case examples. These are all from our lab here at Yale. The first case will be a definitively positive case. The second case will be definitively negative, and the third case will be equivocal in the case in the setting of AL amyloidosis. Here are my disclosures. This is my favorite amyloid slide. It has nothing to do with PYP imaging, but it's an example of what the disease that we're dealing with. This is an explanted heart from a patient with V142I ATTR cardiomyopathy that was explanted in the setting of heart transplantation here at Yale. As you can see here, the heart chambers. Let's see, is this working? I'm supposed to be able to click on this and give us
left click?
Yeah, I'm left clicking. Not working. Anyway, the center of the heart here obviously stays expanded, and it's an example of the profound extracellular matrix that deposits in the context of amyloidosis and the restrictive cardiomyopathy. So really, this is what we're going to be imaging, and this is the disease process that we're dealing with. So let's start with our first case. As background, this is the case we're going to be looking at that has grade 3 uptake and is unequivocally positive. So this is a 73-year-old black male with a long-standing history of severe left ventricular hypertrophy and echocardiography, a biventricular dysfunction and heart failure, who had underwent a cardiac MRI exam which showed diffuse late gadolinium enhancement. As you can see on the left image of the MRI, there is obvious hypertrophy that is concentric. And on the right image, this is a gadolinium-enhanced image that shows diffuse late gadolinium enhancement throughout the left and right ventricular myocardium. This patient, and all patients who are going to undergo evaluation for ATTR, did undergo evaluation for plasma cell dyscrasia. The kappa free light chains were slightly above normal. Lambdas were normal. The kappa to lambda ratio was normal. And this is interpreted in the context of his creatinine clearance, which was mildly reduced with a creatinine of 1.3. I'm hearing is everybody hearing my audio okay? The SIFE and UIFE were both negative, and the patient had underwent genetic testing which showed V142I gene positivity. Planar images taken at 1 hour showed diffuse grade 3 uptake. This is an anterior view on the left and a lateral view on the right. And while you can't see it on the bottom, we're using a matrix size of 256 by 256. These are the standard recommendations from the ASNC practice point. So So you can see that there's diffuse myocardial uptake. You can actually see a little bit of the outline of the myocardium, and the uptake is greater than the surrounding ribs. When this is quantified using a heart to contralateral chest methodology, our mean count of the heart and the lung ratio is 2.03. The heart region of interest is in red here, and obviously the contralateral chest is in yellow. Now, what you're wanting to do, as Dr. Bourque mentioned, is make sure your cardiac region of interest is surrounding the heart and not surrounding overlying structures such as the lungs. There is a little bit of lung rim of lung that's obviously incorporated into this the heart ratio in this case. In our laboratory, we perform SPECT-CT imaging, and this is an example of the SPECT-CT fusion image. What you have here is the emission image colored in the cool color scheme. This is the technetium pyrophosphate uptake overlaid on the attenuation correction CT map. And what you're seeing is obviously that the cardiac uptake is within the myocardial borders. This is a key quality assurance mechanism, as Jamie mentioned, to ensure that the uptake is not within the blood pool. When we reconstruct these images using a SPECT methodology, you see that the uptake, and this is the uncorrected and the attenuation corrected images displayed here in short-X in standard cardiac orientations, that the cardiac uptake is diffuse, although more prominent in the septum, and that's a classic hallmark, but actually looks like a perfusion study performed for stress testing. So in this summary image, you have a very positive grade 3 planar image, a heart to contralateral chest ratio that's over 2, and a SPECT-CT fusion image which shows myocardial uptake. In these patients with a high pretest probability, like this gentleman, there is extraordinarily high diagnostic accuracy of PYP. In this case, this patient was started on tafamidis for treatment of his cardiomyopathy. Our next case is a case that shows a definitively negative study. This is a 67-year-old white woman with peripheral vascular disease, atrial fibrillation, and cirrhosis. She was admitted for congestive heart failure and volume overload. While she has known LVH, obviously her echocardiogram here does not have the classic amyloid appearance. There's mild left ventricular hypertrophy, and I'm not going to show you the rest of the echocardiogram, but suffice it to say it doesn't have a classic amyloid appearance. Nonetheless, the patient had kappa and lambda-free light chains performed, which were both elevated, consistent with a polyclonal process in the context of the patient's peripheral vascular disease, cirrhosis, some ongoing infectious issues, and not indicative of monoclonal gammopathy. Her serum immunofixation electrophoresis was negative. Here's a planar image for the anterior on the left and the lateral on the right, taken at 1 hour, again a 256 by 256 matrix. What you can see is the patient's chest is actually very narrow, and there is no uptake in the area of the myocardium, either anteriorly or laterally. You do see photopenic areas around both kidneys and subdiaphragmatic photopenia, and we'll get to what that indicates in a later slide. Quantitatively, the heart to contralateral chest ratio, as you can see, is very difficult to accurately interpret in this patient, but suffice it to say it's consistent with the negative image, and the heart to contralateral chest ratio is 1.06. Moving on to our SPECT-CT fusion image, as opposed to our positive study in the last image, you see that there's no myocardial uptake. There's just some diffuse background uptake predominantly in the ventricular cavities and overlying the sternum. There are also bilateral pleural effusions, and this patient had ascites, which was the cause of the photopenic areas on the planar images. Now, in cases where there's no uptake, the SPECT reconstruction can be challenging for the technologist, which is why, as Jamie showed you, an axial reconstruction is sometimes more useful. If you were just to see this particular SPECT reconstruction, it's obviously very difficult to interpret what's going on. In this case, we have a negative planar, negative HDL, negative SPECT-CT fusion. There will be further examples of extracardiac findings in later slides, but in this particular case, you're dealing with a patient who had cirrhosis with ascites. My last case is an equivocal study. This is a 78-year-old woman with a history of atrial fibrillation, a recent onset of heart failure with preserved ejection fraction, acute on chronic kidney disease with proteinuria, a left atrial thrombus, and admitted with volume overload. As part of our screening for plasma cell dyscrasia, she had markedly elevated kappa-free light chains, 10 times above normal. In addition, she, on serum immunofixation, had 2 monoclonal kappa proteins. Her echocardiogram obviously is quite strikingly abnormal and consistent with amyloidosis with diffuse myocardial thickening, including the interventricular septum and the right ventricular free wall. In this setting, she did undergo PYP imaging. Now, what you can see here is on the anterior image on the left, there is some suggestion that there's some radiotracer uptake in the area of the heart. And in some cases, we've seen these types of images be called positive. These are the images, these are the heart to contralateral chest images performed at 1 hour. You see that the region of interest on the contralateral chest is very problematic because it includes areas of diaphragm. The heart to contralateral chest ratio measured by the technologist was 1.38. Here's a SPECT-CT fusion image. Now, we had seen before that there was some area of uptake in the heart, and as you can make out, there is a myocardial contour here on the SPECT-CT fusion image. There's obviously bilateral pleural effusions that are quite striking as well. Here's the non-corrected and attenuation-corrected SPECT images performed at 1 hour. Because there was blood pool uptake, and because of the equivocal nature of the study on the planar imaging, she was brought back for imaging at 3 hours. With 3-hour imaging, you get increased uptake of the PYP in the bones. As you can see here, the rib uptake becomes much more pronounced. The myocardial uptake in this case persists. This would be a visual grade 1 to 2, I would say, and I don't think that with any certainty we could make much more of an expert opinion or commentary about the myocardial uptake, other than to say there is some mild degree of myocardial uptake in this planar image. Quantitatively, it's still negative quantitatively from a HCl ratio perspective, but that HCl ratio obviously includes areas of predominant rib uptake on the right-hand side of the patient's chest. The SPECT-CT fusion image again shows a faint myocardial contour, and the SPECT image itself shows myocardial uptake. Now, in this case, this patient was diagnosed with AL amyloidosis and unfortunately rapidly expired from a PEA arrest. And what this demonstrates is that there are studies where you have equivocal low-level PYP uptake that can be challenging to interpret. In some cases, a 3-hour image may help clear the blood pool and increase our certainty about myocardial uptake. In this particular patient with AL amyloidosis, or if you're unsure about AL amyloidosis, an endomyocardial biopsy with mass spectroscopy, a confirmation of the amyloid protein, is critical to further make the diagnosis. So this is our team at Yale. I'd like to thank all of our amyloid team, and again, thanks for FASNC for inviting me to make this presentation. The next speaker is Dr. Saurabh Malhotra from Cook County and Rush Medical College.
Thank you, Ed, and thank you everybody for joining. Big thanks to FASNC for arranging this very valuable webinar. These are my disclosures. I'm going to be sharing 2 interesting cases that show the challenges in imaging and interpreting these studies and how to clinically manage patients. The first one is that of a 65-year-old African-American gentleman. He has a known history of HFrEF with an ejection fraction above 25%. He carries a past medical history of hypertension, chronic kidney disease, stage 3, and diabetes. Previously reported non-obstructive coronary artery disease on a prior coronary angiogram done at another institution. We had attempted to perform a cardiac MRI to evaluate the cause of his cardiomyopathy, but that was not performed due to claustrophobia, and the patient reported compliance with his heart failure medications with no heart failure admissions. He does suffer from significant peripheral neuropathy, presumed to be from diabetes, and is wheelchair dependent. And from complete sake, from a history standpoint, since we're talking about amyloid today, there was no history of bilateral carpal tunnel syndrome, lumbar stenosis, orthostatic hypotension, or GI disturbances, the so-called red flags in amyloid heart disease. His EKG is shown here that shows a sinus rhythm with some intraventricular conduction delay Possibly one could say there was low voltages, but doesn't meet the classic criteria for low voltage EKG. This is an echocardiogram. It takes a little while for the videos to play, but so I'm going to skip that. But essentially showed severely reduced left ventricular function, mild left ventricular hypertrophy and biatrial dilatation. And similar to what Dr. Miller just showed, doesn't really look like an amyloid echocardiogram. However, at our lab, we perform strain imaging on all our patients. And in this patient, the speckle tracking analysis showed apical sparing pattern. And if you did the calculation, it comes out to be 1.12, which would be consistent with apical sparing. And our astute echocardiographers did mention in the echo report to consider further evaluation for infiltrative cardiomyopathy, specifically that for cardiac amyloidosis. This patient did undergo assessment of serum and urine free light chains, which were negative, and then was referred for PYP scintigraphy. And he was one of our earlier patients. We injected 15 millicuries of technetium pyrophosphate, imaged him at 1 hour and 3 hours both. This is his 1 hour planar image depicting a visual grade of 3, but an HCl ratio of 1.3. You may think of this as an indeterminate study based on the HCl ratios being less than 1.5, but we largely rely on the visual grade more so than the HCl ratio. Because of this indeterminate finding, and this was in early days in our amyloid experience, we performed 3R imaging as recommended at that time, which continued to show prominent cardiac uptake even at 3 hours. And this was classified as a grade of 2, given that the rib uptake had increased and the myocardial uptake had reduced somewhat. The HCl ratio appropriately went down to 1.2. We have been performing tomographic imaging with SPECT since the very beginning when we started doing PYP imaging, and this was a tomographic reconstruction of the 1 hour SPECT, the 1 hour planar images that really does not show the typical myocardial contours that one would expect, as previously shown by Dr. Miller. And this was really confusing and concerning for us because we did see a pretty prominent uptick on planar imaging, but did not correlate with a myocardial uptick on SPECT images. And this was repeated on the 3R imaging as well, and again we see a similar distribution of blood of uptake, tracer uptake that does not conform to myocardial contours. One should be able to see a short axis image here like a donut, a vertical long axis and a horizontal long axis, but we did not see any of the typical myocardial contours. And this is how we interpreted the study. The 1R imaging showed visual grade of 3 on planar scintigraphy with no evidence of myocardial uptake on tomographic imaging, and 3R imaging also depicted visual grade of 2 on planar scintigraphy, both of which would be positive, but no evidence of myocardial uptake on tomographic imaging. And we interpreted this as following. Collectively, these findings do not suggest myocardial PYP uptake, and we opined that the high visual scores on planar imaging are likely due to blood pool activity in this patient with severely reduced ejection fraction. This is not an unusual finding. These are some other cases where you can see prominent tracer uptake on planar imaging with complete absence of myocardial uptake and essentially blood pool activity on SPECT reconstruction. We have recently published this in JNC showing the possibility of false test results with planar imaging alone, more so when HCl ratios are used independently than visual score on planar imaging. We recommend always to perform SPECT. We perform SPECT on every case, and we've been doing it for many years now. Planar imaging alone can result in studies being classified as indeterminate. Misclassification in our experience mainly stems from HCl ratio. A visual score alone can misclassify a small proportion of patients. However, given the diagnostic, therapeutic, and prognostic implications of these planar findings, they should always be confirmed on SPECT to make a correct and more certain diagnosis. And if you, of course, have a SPECT CT, then more so with a SPECT CT. Moving on to the next case, this is that of an 81-year-old African-American lady with heart failure and intermediate ejection fraction of 40 to 45%, who was admitted with heart failure a little over last year. Now, two contrasting cases here, somewhat younger African-American gentleman with HFrEF and much older octogenarian lady with intermediate EF who has heart failure admissions. She had a prior heart failure admission 3 months ago. She has dyspnea on limited exertion, has tense edema up to her knees and a positive JVD. She has mild dementia. She is compliant with her heart failure medications, which is insured by her granddaughter, who is a nurse. She has a past medical history of persistent atrial fibrillation and hypertension and CKD stage 3. She has generalized weakness and gait imbalance and walks with a walker. And again, because this is an amyloid webinar, we must highlight that she has no history of bilateral carpal tunnel syndrome, lumbar stenosis, orthostatic hypotension on clinical evaluation, or GI disturbances. Her EKG shows atrial fibrillation and definitely low voltages, as you can appreciate here. Her echocardiogram, again, I'm not going to play the videos in a sense of time, but showed mild to moderately reduced ejection fraction, moderate left ventricular hypertrophy, wall thickness of 1.4 centimeters, and severe biatrial dilatation. Again, similar to our previous patient, all our patients at County get spectral tracking echocardiography performed, and in this case as well, she had a pretty prominent apical sparing pattern, and our astute echocardiographers find that we should further evaluate her for infiltrative cardiomyopathy and specifically for cardiac amyloidosis. She could undergo cardiac MRI, which showed diffuse late gadolinium enhancement on phase-sensitive inversion recovery sequences, and of course we performed the serological studies, which interestingly were mildly abnormal. Serum kappa lambda ratio was 4.2, upper limits of normal is 1.8, and urine kappa lambda was similarly mildly elevated. However, this was enough for our pathology lab to continue with ongoing evaluation, and her serum and urine immunofixation electrophoresis was also positive for IgA kappa expression. She underwent PYP scintigraphy to confirm or to elucidate what kind of amyloid she has. She had a visual grade of 3 on planar scintigraphy with an HCl ratio of 1.9 and a positive tomographic scan, and this is what it should look like. You see the short axis, the vertical long axis, and the horizontal long axis. In the views, you can see the myocardial uptake, and this would be focal on diffuse, in my opinion, with marked focal uptake in the septum as compared to the lateral wall. So this study was reported as the following: a visual grade of 3 on, with HCl ratio 1.9, along with tomographic evidence of myocardial PYP uptake. Findings are highly suggestive of TTR cardiac amyloidosis, and correctly our reader reported that they recommend serum urine immunological studies to rule out light chain amyloidosis and also to perform genetic testing, which was performed in this patient, and she had the V142I mutation. So she is a particularly challenging patient. Not only does she have features of TTR amyloid and definitely the genetic risk for it, but she also has elevation in serum and urine kappa chains. Because of these conflicting findings, hematology oncology was consulted, who performed a bone marrow biopsy that further complicated the diagnosis because she had 18% plasma cells in a bone marrow but no evidence of light chain amyloid. We did want to further pursue tissue biopsy, but the family declined given the debilitated state of this patient, and they wanted to continue with conservative medical therapy alone. We did perform skeletal surveys to assess for bony lesions. There were none. And the patient was managed for heart failure with escalation of diuretic regimen that did result in significant improvement in her edema and her dyspnea on exertion. We noticed no clinical deterioration, actually clinical improvement over the subsequent months. And at 6 months, a clinical decision was made between hematology and cardiology that her features, her clinical presentation is actually more consistent with TTR cardiac amyloid, because if this was multiple myeloma and AL amyloid from multiple myeloma, she would have deteriorated fairly quickly. She is we continue to follow her, and at 12 months, there is clinical and hematological stability and no worsening of her immunoglobulin light chain assessment. Assessment of monoclonal gammopathies is very, very important. This can be MGUS, smoldering multiple myeloma, both of which are pre-cancerous, pre-malignant stages of multiple myeloma. What segregates multiple myeloma from the pre-cancerous stages are the presence of the CRAB features, hypercalcemia, renal insufficiency, anemia, and bony lesions. And none of these were present in our patient, and our patient actually fell in the smoldering multiple myeloma category. And so she's a unique patient who has both TTR, cardiac amyloid, and smoldering multiple myeloma. Knowledge of monoclonal gammopathies is important. These are prevalent in the elderly, which is also in whom TTR cardiac amyloid is prevalent. So it is not unlikely to see them coexist, and some studies have reported up to 40 to 50% of patients with biopsy-proven TTR cardiac amyloid to actually have monoclonal gammopathy. If this occurs, consultation with hemonc is required, and when possible, tissue diagnosis should be obtained. A close clinical follow-up is essential in these intermediate cases with MGUS and smoldering multiple myeloma, because there is a chance of 1% per year progression to myeloma in these cases. And I cannot emphasize how important it is to rely on a collective clinical judgment strengthened by the laboratory and imaging evidence to decide what diagnosis the patient has and how you would manage this patient. Thank you, and I now pass it on to Dr. Sperry.
Perfect, thank you. And thanks to ASNC for inviting me to speak at this webinar. I think this is a good opportunity to really get through the nuts and bolts of interpretation and reporting of these PYP scans. Here are my disclosures. And so I have a couple cases here to finish off the case portion of this webinar. And my cases are more focused on the HCl ratio and the difficulties in actually drawing the circles, the region of interest, and in reporting, and some pitfalls that you may see with the ratios that you derive from the planar image. So the first patient here is an 80-year-old white male with a history of coronary artery disease, bilateral carpal tunnel syndrome, arthritis, and he presented with heart failure symptoms. You can see his echocardiogram here, which may or may not load, but there's certainly some increased LV wall thickness, particularly in the septum. Can visualize maybe some lack of longitudinal motion of the myocardium. I don't have all the echo images here, just the first shot. And as Dr. Malhotra was talking about, we do want to think about red flag symptoms such as carpal tunnel in these patients, bicep tendon rupture, spinal stenosis, these neuropathy, these types of things. So here's his 1 hour planar image, and I'm showing the 1 hour, but we did do a 3 hour, and it was not any better. So this patient is very rotated here, which becomes a challenge for where do you put your region of interest, where do you draw your circles here when you're trying to assess the heart to contralateral lung ratio. You see there's you see where the heart is localized here. If you put your circles here, these are the numbers that you get, and you get a ratio of 1.17. Part of the issue with this is that you're trying to avoid the sternum here, but you also have the spine, which is very hot in the back here. So if you put a ratio, the contralateral lung ratio here, you're going to get a lot of this uptake from the spine, and so that can be a problem. So where else can you put this circle? Well, you want to ideally put it above the diaphragm, avoid the spine and avoid the sternum, and avoid going too far out laterally, past the chest. And I don't know that there's a good area to put it. If you put it here, you're getting pretty. If you put it here where this arrow is, you're getting pretty far lateral out there. If you put it down here, you are getting into the abdomen a little bit. And if you did put it down here, then you get a ratio of 1.58. So you can see that where you put these circles really can matter when it comes to generating this HCl ratio. And you can misdraw the circles and make the ratio whatever you want it to be in some respects, especially in a difficult image like this where the patient is very rotated. So more important than ever in a situation like this, you want to look at your SPECT images. And this is a 3-hour lateral, and so you do see some myocardial uptake here. And this is the SPECT showing uptake localized to the myocardium, mostly in the basal and mid segments. Additional information on this patient: he had an NT-proBNP of 16,000 and a troponin I of 0.08. So several factors here that are consistent with the diagnosis of amyloidosis, likely ATTR amyloidosis. And so this is how we summarized the report. We actually did not report an HCl ratio here because of the issues that we talked about, and I think that's something important to point out with all of these studies. Patient is being referred to this study to make a diagnosis of amyloidosis, positive or negative, and the worst thing you can do is to not have diagnostic certainty and give a diagnosis of positive or negative of amyloidosis, whether you're looking at the planar or the SPECT or whatever. So realize that there may be some studies that you're not totally confident on reporting on, and it's okay to say that. So we reported here unable to quantify HCl grade 2 uptake on the planar image, and then on the SPECT image we said that there was radiotracer localized to the myocardium, and then of course we have our statement talking about AL amyloidosis and the fact that needs to be separately evaluated. And there's various algorithms for this that have been published, but usually to start with blood and urine testing for a plasma cell disorder, kappa lambda and ratio, free light chains, and serum and urine immunofixation. So our second case here, similar theme with respect to the HCl ratio. You have an 87-year-old man, permanent atrial fibrillation, chronic systolic and diastolic heart failure, CKD, came in for heart failure and had a fall at home. The initial plan was to get an echo and to start diuresis. This was not previously diagnosed as far as amyloidosis, but you see kind of diffuse thickening of the LV myocardium. You see low tissue Doppler measurements here in the lateral and also on the septum on tissue Doppler. So you do have a concern that there may be amyloidosis here. You have the right patient demographics. And so here is the study. This is the 1 hour anterior image, and then here's the lateral at 1 hour. What you see is marked rib uptake here, which ends up being rib fracture. This is a patient who had fallen at home. But you do see some uptake localized to the myocardium. You don't appreciate it as much on the 1 hour, but you do see it more so on the lateral image here. And you can almost, like Dr. Malhotra was saying, you can almost see the donut of the myocardium on this lateral view. But of course, we want to look at our SPECT images and see what that looks like. So in this one, interestingly, if you include the rib for the ROI versus if you don't include the rib, you have very similar HCl ratios. In this case, it's probably because there seems to be rib fractures on both sides. But you do want to try to exclude those if you can, and so I think a region of interest drawn like this would be a little bit more appropriate than the one looking over the whole heart where you do include the rib fracture. So we do look at SPECT here, and this patient actually had quite mild uptake in the myocardium, which would go along with the more mild findings seen on the SPECT, or sorry, seen on the planar image. So this patient, we said the HCl ratio was 1.46 at 1 hour. At 1 hour, the planar was maybe more like grade 1 even at 3 hours. But there was SPECT images with radiotracer localized to the myocardium, and so we had a similar comment here. Of course, when you see lower levels of uptake here, obviously you do worry about AL, and so this patient actually underwent testing for plasma cell disorder that was negative, and this was an earlier patient that we had from several years ago, actually did get an endomyocardial biopsy, which did confirm ATTR. And so those are the couple cases focusing on the perils of the HCl ratio and the importance of looking at SPECT. And so I'll leave it there, and then I'll turn it back over to Dr. Bourque for the discussion.
Thank you, Brett, and I want to thank all of our speakers for these great cases and I think really helpful insight into sort of the thought process when interpreting these images. Importantly, I think some themes that have come across have been the importance of adding SPECT imaging, and there's definitely been discussion about sort of the timing of imaging. So we're going to move into the panel discussion and audience question and answer phase of our webinar. And it looks like we have a nice 13 minutes left, so we should be able to get some good discussion going. And I will start by addressing, there have been several comments about timing of imaging and whether to do imaging at 1 hour, 3 hours, and should one repeat. And so I will open it up by saying that at UVA, we are typically imaging at 1 hour, and if there is any blood pool activity on the images, or if we're unable to make a definitive visual grade, then we are repeating imaging at 3 hours, and we have found that to be helpful. But I'd be curious to hear what our other speakers are saying. One person had also asked, is it feasible or reasonable to do imaging, just do imaging in everybody at 3 hours? And indeed, an approach where you did imaging at 2 hours or imaging at 3 hours in all cases would be a very reasonable approach as well. So to the rest of our panel, what are your thoughts?
Hi, this is Saurabh Malhotra. So I agree. I think if you involve SPECT imaging in all cases, in our experience, we don't need repeat imaging. You may perform imaging only at 3 hours if that is how the throughput of your lab works, and I think that's fine as well. And I know some labs who do just 3 hour imaging as well. And I think if you are using SPECT to confirm myocardial uptake, then I believe that is acceptable. I think that should be okay to do as well.
It's Brett Sperry. I'll chime in here. So we were actually talking about this, the three of us before, 4 of us before the session came on, and I think there is a lot of heterogeneity in how different centers approach the timing. Certainly the 3 hour protocol is longer. It takes more resources. In addition, since the patient, during COVID now, we're cognizant of patients being in the hospital for longer, sitting in the waiting room. So we overlapped with both 1 and 3 hour images for a few years, and then published our data recently. And the group at UPMC published our data as well. And we we did not see any major differences between the 1 and 3 hour images. That is with a SPECT CT protocol that we did. So we've become very comfortable interpreting our images with planar and SPECT CT at 1 hour, and then sending the patient home after that. We haven't seen, some patients will still have some blood pool at 1 hour, and we didn't see, and I don't know of any reported cases of where the SPECT, the high quality SPECT or SPECT CT was negative at an earlier time phase, meaning 1 hour, and then became positive later at 3 hours. And so we've been comfortable stopping at the 1 hour. And I'll turn it over to Dr. Miller to see what his thoughts are.
Yeah, so I think I agree with you. If you have SPECT CT, a 1 hour protocol is straightforward. Most places are not going to have SPECT CT, then you have to make a workflow decision. If you get 90%, 80%, I think of studies will be fine at 1 hour. If you can do SPECT, you have to do SPECT with those as well. But there will be 10 to 20% of cases, depending on who you're testing, that you're going to want to have a delayed image on. And so you have to make a workflow decision about whether you can review those in real time and advocate for the 3 hour imaging, or whether you should just do 3 hour imaging alone, realizing that it's going to have its own issues for workflow for the patient. We were talking about that in our technologist meeting yesterday in our laboratory, and technologists were saying, well, you can inject them and send them home, or send them out of the hospital or out of the clinic for 3 hours. That's obviously not ideal. So if you can get away with the 1 hour imaging, it's going to probably be the most efficient. But there are going to be certain scenarios where a delayed image is going to be useful, and you have to be prepared to do that.
I would also like to say that sort of highlight the fact that our panel are all in centers with a fair amount of experience now with amyloid imaging and with PYP imaging. And so I think it's perfectly reasonable when you're getting a lab started to consider doing imaging at both time points to get experience with sort of your visual interpretation of what things look like at 1 hour versus 2 or 3 hours. And I think it's reasonable to also, consider starting out with sort of later imaging, and then as you become more familiar, considering moving to a more efficient protocol as well. So I think there are a lot of ways that you can proceed. Another set of questions that has come up in our chat here is how to reconcile discrepant HCl ratios with visual grade. And this was something that I had tried to highlight in my initial discussion, is that we really have gone away from reporting HCl ratio in all patients and really gone to predominantly using the visual grade with assessment of the HCl ratio either for prognostic purposes or in a setting where there's equivocal, say grade 1 versus grade 2, in which case we incorporate that in. So if a patient, one question was, what do you do if there's the HCl ratio that's sort of getting towards 1.5, but your visual grade is clearly 0? So in that case, the study is negative and your visual grade is 0, at least per the consensus statement, and I'll ask our panel. Likewise, if you have grade 2 or grade 3 uptake, then you're really done at that point. And if you have an HCl ratio that's less than 1.5, it may just be challenges in where you're drawing your region of interest. That is how the consensus statement has kind of looked at this and how we do at UVA. I'd ask the panel, any additional sort of thoughts on that or other insight?
Well, it's a great summary. It's just like sort of like analogous to TID, right? You have to confirm it visually, and if you have bad numbers in your calculation, it doesn't matter. The output's going to be bad too. So the visual confirmation is really key.
Yes, I agree with Jamie and both Ed as well. We report HCl ratios, and there might be prognostic value to them, and maybe in following up treatment response. I see one of that question here, but from a standpoint of calling a study positive or negative, we really don't rely on the HCl ratios. Actually, we just published a paper showing when there was SPECT evidence of myocardial uptake, almost half the studies had an HCl ratio of less than 1.5. So we have moved away from relying on HCl ratios from a diagnostic standpoint, but I think it may still have prognostic value and thus may have value in keeping it in the report.
Yeah, and so I think, Jamie, this is a really important question that comes up, and I've seen outside studies where an HCl ratio is high, but review of the SPECT image shows only blood pool, and the study is reported as equivocal. So, I think that's the wrong interpretation of the study. If there's no myocardial uptake on the SPECT images and it's blood pool, then that's a negative study, and you can kind of throw away the HCl ratio that you see on the planar image.
That's really helpful. I think that's definitely correct. So I appreciate everybody's thoughts on that. Another question that has come up is sort of role of endomyocardial biopsy. And I was curious, you all have a lot of expertise both in the cardiac amyloidosis clinics as well as in the nuclear lab, as to in what settings are the endomyocardial biopsies being used sort of based on the PYP results? And in what percentage of patients do you think they're being used?
Yeah, I can take that one. There's been a couple of questions about whether or not you need, whether you should do the plasma cell dyscrasia workup first. And I think that the answer to all those questions is yes, you absolutely need the plasma cell dyscrasia labs, but in order to interpret the PYP study and vice versa. But they're not mutually exclusive. AL and TTR are distinct diseases, and you can have one, neither, or both. You can have AL amyloidosis and TTR amyloidosis. Usually the AL would be involved in other organs at that point. So our biopsies, we're doing biopsies for patients who have evidence of a plasma cell dyscrasia by labs, who have a positive bone marrow biopsy. Just like in Saurabh's case, we would have, as he tried to do, recommend the endomyocardial biopsy for that patient. And this is coming up frequently, particularly in African-American populations who are V142I positive. They have AL amyloidosis, and they also V142I positive, and there's no way of making that diagnosis other than the endomyocardial biopsy with mass spec.
That's helpful. Brett, any other thoughts on that? I know you're very involved in the amyloid program.
Yeah, I agree with all of that. I think the major time that we're doing biopsy now is when there are, there's either AL. Obviously everyone who you think has AL needs a tissue diagnosis somewhere, whether that's a fat pad or a bone marrow or a heart biopsy, and then people who have a positive or a borderline positive PYP but have abnormal testing in there with respect to plasma cell disorder, you need to think about moving ahead with tissue diagnosis of the affected organ.
But I would also say on the flip side, if somebody has abnormal free light chains, that doesn't mean they don't have TTR too. So you just can't say somebody has LVH and has abnormal free light chains and even a monoclonal protein, and so therefore they don't need the PYP. You can have both simultaneously. So you can't exclude TTR by having a plasma cell dyscrasia.
Absolutely.
And one last sort of question before we finish up. RV uptake of PYP, can you all comment on that quickly?
It's usually, we usually see more septal predominance. There was a question about apical sparing is too. We're not exactly sure what the geographic or regional variability means. other than there's been reports. And this may also be partial volume effects on the nuclear scintigraphy related to the differential hypertrophy, but you certainly do get some RV uptake.
So I want to be respectful of everybody's time, and it's 1 o'clock. I thought we had great cases. I want to thank again our panel for bringing great cases, and thank you all for having great questions. And we had a nice, robust question and answer. We will look at the remaining questions we were unable to get to and put out something by email with responses to those questions. I want to thank again ASNC for sponsoring this important area for further education in cardiac amyloidosis, and thank you all for coming.
Great. Thank you so much, Dr. Bourque, and to our other speakers as well. Of course, the audience for your participation. Please stay tuned for additional information on future events on the ASNC website. This program is copyright 2020 by the American Society of Nuclear Cardiologists. Have a wonderful day, and you may now disconnect.